to do that. Oh, I guess we have recording in progress now. So, okay, good. Now I can say whatever I want. All right, so let's move on. Anybody have time constraints? I see we got Pierre on, and that's great because I want to hear from him. And we have some new people that are going to be on the program today that I will introduce. And also we're going to hear some follow-up from various other organizations as well. So first of all, this is just started off as usual. This is the gathering of the so-called jurisdictional medical directors from the largest cities in our country and some elsewheres, and plus all our friends that help us out from liaisons from various other organizations and institutions. So with that, I'm going to go ahead and get started then. And hopefully we'll have some of the other folks. Hey, Peter, can you make sure you text for me and see if we get Scott on so he can do a reprise of that thing, later this morning, okay? So if you don't mind. Okay, good. And then also I'd like to see, will you be able to give a presentation, that maybe part one of the thing you did on whatever it was, Friday morning, I think?
Yeah, absolutely.
Okay. Good. All right. Anybody with time constraints? If not, I'll just go on and launch things and talk to Pierre first overseas. And so we want to know what the monumental challenges that you have over there, the intercontinental monumental pit challenges. I can't remember what I wrote this morning, but Pierre, what's going on in Paris and across France? Well, even Europe. So Pierre, Carly, see if I can get it plugged in. He's at least signed in. Maybe he's distracted, which wouldn't be a surprise to me. So, okay. Hey, Pierre, if you're there, okay, bonjour. All right, so maybe he's on hold or something like that. Okay, thank you.
Oh, sorry.
Yeah, no, it's good. Hi, Pierre, just glad to have you here. So go ahead. So what's the latest from Paris, France, and the rest of the European continent?
Okay, a quick report about Paris and what we are doing at the time being. As I explained before, you'll be connected. It's a very strange situation that we have in France at the time being. We have a very important number of contamination that we have never seen before. Clearly, Omicron is clearly overwhelming France with viruses. However, the effect on the healthcare system is less than we expect. And most of the patients have few or limited signs of infection, mostly let's say gnats, throat sore, things like that. And we have only the non-vaccinated and the patient with immunological deficit that are making very severe forms and COVID ARDS. So at the time being, we have been with a very important number of calls to the EMS system, but we succeed in the fact that the patients were not all transported to the emergency room. They stay home with daycare basis treatment, and only the severe case were sent to the hospital. And consequently, we have a lot of patients in hospital, but we are not overwhelmed as we were in the previous wave. At the time being, most of the patients are not in intensive care unit. They are hospitalized in medicine ward, and that's globally non-severe patient as compared to what we have seen before. So the question is now, will the situation will decrease or increase in terms of patients at the hospital? In the past, let's say 4 or 5 days, we observe a decrease of call, a decrease of transport of patient transport to the hospital. So we are thinking that in several regions of France, the situation now is decreasing in number of impact of the crisis as compared to before. However, as I told you before, as in many countries, we have another problem. The other problem is it is winter. We have a lot of patients that needs critical care, not related to COVID, but clearly the pressure on the hospital and the ICU stay very high level. But in effect, we are not overwhelmed, and that's a good news for us because we thought a few weeks ago that it will be terrible at the middle of January, and it is not yet. or maybe it will not be as difficult as we thought. This is the quick report from Paris.
Oh, fantastic. And not today, but maybe down the line, be thinking about as a critical care person, and particularly as someone who takes care of children, pediatric critical care. I may do a presentation, I think within the month or so, where I'll bring in some intensive care people and who do science in this area and describe how the traditional ARDS we've had in the past is different pathophysiologically and also management wise. Just now, what have we learned, 2 years later? Because remember, we got to the point where first we were treating the happy hypoxemics and that we were finding out maybe this is a different disease than ARDS that we traditionally had. So it would be kind of nice to have a recap of that, especially now that we know a lot more about the pathophysiology and then the resulting management that's needed. Okay. So it's good to see you. Otherwise, are you hearing anything else around Europe? Is there any other signals coming from some of the other countries that you're aware of, Brussels or Germany or Italy?
Yeah. In many countries, they observe that they have non-severe cases compared to the other waves. However, the number of patients is incredible. We have hundreds of thousands people contaminated every day in France and in all Europe, everywhere. So consequently, the number of patients contaminated is we have never seen that before, but it's less severe. So that's the important point. And we have learned how to manage this patient more efficiently.
So the problem that you're having, as well as us, is that despite the fact that it is less severe, there are just so many more people with it. As a result, our medical staff are getting wiped out, or having to be put off or
Exactly.
see them. And you're having the same situation over there as well, right? And how are you getting around that? Or are you?
Yeah, we are trying too, but it's quite difficult. However, it's clearly less than we thought. That means at the time being, the important point was critical care, because the critical care teams were exhausted and they do not want to manage one more patient. Yeah. But at the time being, it's only very few limited admission to critical care. So the maximum effort is on conventional wards, medicine wards or surgical wards transformed to COVID wards. So clearly it's more simple. And indeed, we had to use again students, volunteers and people like that to reinforce hospital. But the only thing that we are not able to do is to reinforce the critical care unit. So the good point is that admission are limited, because this is the point, very difficult to manage.
Okay, that's helpful then, which is a good pivot to one of the problems we're seeing here is some hospitals are just overwhelmed. Even the people just coming worried well in a sense to see if they're positive and wanting to get a test, and I could go on and on. But one of the things that hospitals are doing as a result are going on diversion, which means don't send any patients here. And of course, that's something that bothers us, or we're waiting outside holding on to patients. And someone who's approached that in the state of Indiana has been Mike Kaufman. So Mike, can you tell us a little bit about your experience there and what you've done, and has it helped?
Yeah, hey, Paul.
Yeah.
Thanks, everybody.
Made things worse, right? Right.
It certainly could. So, diversion is nothing new. We've all experienced it both during normal operations as well as during these pandemic times. It really kind of reached a point last week where we had nearly 40 emergency departments in the state all on diversion at one time, with some facilities having been on diversion for 52 straight days. That's 24 hours a day, 7 days a week. Now, clearly that wasn't doing any service to our EMS provider agencies and the patients that they care for and transport. This has really been an ongoing effort and an ongoing dialogue, and we had to work to engage all of the stakeholders here in the state. So that meant the Hospital Association, the Department of Health, the Department of Homeland Security that oversees EMS operations, and even our larger provider agencies. And really just through direct dialogue, showing them the impact that this was having on our ambulance operations, our ability to stay in service, and ultimately our ability to continue to respond to 911 calls, we were able to collectively get those hospitals to agree to all come off diversion. It happened up in the northern part of our state last week, and happened today in Marion County, which is our largest, most populated county in the state. So as of right now, we have no emergency departments on diversion in the state of Indiana, and they have essentially agreed to stay off of diversion status for a period of 30 days. I think, honestly, I think what that's going to do is it's going to show us over the next 30-day period that, you know, when everyone's on diversion, no one's on diversion, and most ambulances continue to operate by going to the most appropriate facility. I think that this is going to show us that having a no diversion policy can be done, and it can be done successfully to keep ambulances moving and getting patients to definitive care where they need it. And I think the impact is not going to be this sudden doomsday that most of our hospitals think that they were going to experience when they came off diversion. I also think that this is going to help the hospitals internally kind of push the issue of what to do with ED overcrowding, right? Because diversion is not necessarily an ED problem, but a hospital patient flow problem. So I'm going to come back to future meetings here and keep you updated as to the progress. And during this 30-day period, we're going to have ongoing discussions about what's the next step. I was really thankful that the hospitals, the Patient Safety Coalition, the health department were able to get to this solution through engagement and conversation rather than through legislative action or rulemaking. And so far, 2 thumbs up. We'll let you know how it goes over the next 30 days.
So Mike, that begs the next question, which is, are you having a lot more, as we call it, ambulance parking wall time as a result? Okay.
Yeah, that's a logical step. And if it was probably 6 months ago where we all had a meeting and talked a little bit about ambulance offload delays. And I do think that CMS takes a much stronger stance against that practice than they do against the practice of diversion per se. They specifically say that preventing an ambulance from offloading their patients in a timely manner it may certainly impact their ability to continue to receive Medicare and Medicaid funds. So the fact that that's there, I think is going to help. That was one of the things that we did stipulate as part of this trial 30 days was that we really need to not see an increase in ambulance offload delays. So we're trying to track those as well. That creates a little bit more of a problem, but we'll keep you updated.
Okay. So earlier in the year, we had David Wright on from CMS who oversees this area. And one thing that hit me was not only was that it's theirs once we go over the threshold, wherever that threshold is, but when you're on their property. But the other thing was that paramedics, they don't govern paramedics, but they govern the hospital. And to have paramedics practicing in the hospital, in a sense, monitoring patients or taking care of them, is not appropriate because they're not credentialed there, right? And even if they're credentialed on a side job, they're not credentialed that day when they're on the job with them. So they are looking at this a lot. So it's kind of interesting.
Yeah. David's meeting and his email and that discussion that he had in this forum has probably provided the greatest impact to preventing ambulance offload delays in our state. Nice.
Okay, good. That's fantastic. All right. Well, listen, thank you that much for that report. Let's move over to Sandy Schneider at ACEP and get an idea from the emergency department point of view, let alone our point of view, about what's going on across the nation and up your block. All right.
Yeah, it sucks.
Thanks for the official report. Let's go on to the next one.
Yes. As you're getting squeezed because the EDs are getting squeezed, the chairs put out a thing on the listserv asking if anyone had any ideas, and all they did was say it's horrible. Numbers are unprecedented, in many cases double the volume that they normally would see, and ICU beds are basically non-existent. And many people are trying to transfer. One of the problems is that, we've created an urban system for healthcare. So rural hospitals have very serious limitations on what they can do. And they're used to just, if they have a patient that's on a ventilator, they transfer it. Well, that's not an option now. So the rural hospitals are keeping ICU patients. Most hospitals are boarding more patients than they have beds in their ED. And then to add to all the fun of this, the other thing that was uniform among the chairs is there are no nurses.
Right.
And initially they were saying, well, it's our administration that's not getting the nurses, and administration has to get the nurses. But the bottom line is there is no nurses. So it is extremely bleak. The concern is real that when we come out of Omicron, that none of this is going to go away, that there still will be no nurses. There
Right.
still will be no one working the ICUs. There will be, a tech staff is almost non-existent. Respiratory therapists are going down. The numbers are going down. So I think that we have a short-term and a long-term problem here. The short-term, I have absolutely no idea how to fix, and that is for at least the next 2 to 3 weeks, we're going to have double the number of patients coming to the ED. Most of those will not require ICUs, but the number, again, if the number that will need ICU beds is going to be the same, if not higher, just because of the sheer number of patients we have. Our rural hospitals are going to have to keep patients that they've never kept before. There are no beds. There are no. Just a couple quick statistics. We asked people on a survey today, not a very scientific survey, but just a survey. Are there hospitals that are closing beds in your area, in your region? And almost 50% of people said yes. We didn't expect that because we should have probably asked how many, but daily we're hearing about OB services and other things. So it's a disaster. I know that you guys are getting hit really, really, really hard. And the point is the emergency departments are getting hit just as hard, which is doesn't help. So I think, again, long term, we have to think about how we're going to practice emergency medicine and medicine without nurses or with very, very few nurses, because there just aren't going to be any.
And then the complications of that are then some places are hiring paramedics, which of course take them from EMS. And then the other thing is they're hiring in, the travelers, and then the regular veteran nurse at that place has to show the travelers how to do things, so that increases their work. So they said, hey, why don't I get paid more? I'll just quit and then become a traveler, that kind of thing. And I think I heard something about in Pittsburgh. I don't know if Ron's on or not, or maybe what's happening there.
Pittsburgh, they announced that they were starting their own travel agency for nurses to work in their hospitals, which they have a lot of hospitals in their system. I think it's very clever. You're going to have to hire travelers anyhow, so why not make it? Why not just contract with it?
The people who know the system, but they're paying more for them. So that's
they're paying more for them, and they have the ability to move them from hospital to hospital. So they can bring them in from the community hospital to the mothership, or take them from the mothership and move them out. I think it's very clever.
Yeah, I thought about. Hey, can you lower your screen a little bit? I want to see what your shirt says there. It says American College.
Perfect.
Yeah.
It says American College Chief Resiliency Officer.
That's what I want. The CRO, the Chief Resiliency Officer. Promotion or demotion, what is that?
I do. So I also have been asking, whoa, what was that? I also have been asking, how do we keep people coming back to work? And I've been asking my friends who are psychologists and the military, and how do we get people to come back to work when the conditions are this horrible? And they didn't have a great series of things, but they said the most important thing was breaks. Either breaks through the day, if at all possible, and breaks between shifts, if at all possible. So I throw that out there for, it's probably impossible right now. But one other thing, we are meeting with the Joint Commission, because they've been starting up their surveys again. And some of their ideas have been rather bizarre. In one place, for example, they put 6-foot plexiglass, they ordered them to put 6-foot plexiglass plates between people at nurses' stations and other things, which now almost eliminates the potential for communication, and also keeps, somebody said, it also keeps all the germs inside my little cubicle there. So we're talking with them. They also in one place it said no COVID patients could be in the hall, and since all their rooms were already used, they had to, while at least the Joint Commission was there, put all their COVID positive patients in the waiting room, which made no sense whatsoever either. And then the other thing we're hearing is that tests are almost non-existent. Interestingly, in some areas and in some areas in the country, they seem to be in abundance. So if you know anyone in the DC area and you need a test, they do have them. Also, Amazon Business has them, but Amazon Prime and many of the other groups do not have them.
Okay.
Wonderful news, right?
Yeah. Hey, thanks for the cheery news, but we are half past January, so we'll see how it goes. And I'm sure the stock market's crashing left and right today as well, so it'll make it even better. But let's move on though to, if you think you've got it bad, let's move on to other countries. Like we'll go over to Mick. By the way, hey Roxy, how long can you stay on for? Because if you don't mind, I'd like to hear a little bit from you, and that'd be kind of a fun talk. Are you okay today? What's your timing?
I'm okay today.
Okay, good, because I do want to have couple other medical things on first, namely Dr. Antebi gave an incredible, I was so jealous because it was one of the best talks I ever heard. It was just great. Really fantastic work last week. And several of us were there in attendance. And then also Scott Youngquist, who just gave a nice report for us with the Seagulls, the Florida group. And I'm going to have him just get down to the bullet, what he's found so far. But it's going to be interesting. You'll see it's on IM epinephrine. Okay, it'll be interesting. So first, I'll go over to Mick. And by the way, before I go there, our code for today is 15169. For those of you doing CME, 15169. And for those that were on the Seagulls call, Florida, 15168, 15168. And speaking of which, Peter, do you want to introduce? We have a new member from the league from Fort Myers and Cape Coral, league over in Lee County in Floridora, right? Is she on with us? Hey, Caroline, right? Caroline is there.
Yeah,
Can you do the introductions if you don't mind, Peter?
Sure, absolutely. Actually, the first time I met Carolina is when I was visiting up at FDNY, and she was just a great hostess, and she rolled out the red carpet for me there. So that was a great introduction. She's also spent time in Orlando, in Florida, and now she has become the Chief Medical Officer for Lee County EMS, which I consider one of the premier EMS agencies in the entire state of Florida that just have an incredible team. She took over for a pretty legendary EMS medical director, and they love her there, and she's incredible. So Carolina Pereira, welcome to the group.
And then the other thing I was going to say about her is that she also did a stint up in Wichita, Sedgwick County for a little while before she came down here. And when they were recruiting to replace Joe Lemon, who's just fantastic, she just was a great pick. And so we're really glad to have her. So she'll be our Eagle representing, she'll be a dual person like Jeff, Jeff is for Tulsa and Oklahoma City. And so she'll be Cape Coral and / Fort Myers. So it's really fantastic to have you on board. And it was great to see you last week. So you want to say hi to everybody just so they know what you look like, if you don't mind.
Yeah, thanks for the warm welcome. I really appreciate it. And I'm looking forward to learning more from this group. So yeah, thanks.
You were helping to start up this NAMSP chapter in Florida, right? Is that correct the other day? And what are you doing there? Yeah. Are you one of the officers or one of the personnel?
I'm currently one of the officers.
Okay.
And I mean, it's a good group. I think the mission is laudable. So who knows? Maybe we'll try to stay on.
Okay, sounds good. All right. So in the meantime, yeah, please get on their calls every week. I'm glad we were able to get you connected in here. And then let's move over to Ireland, okay, and my homeland, okay. Oh, look at Maloney's on. That's perfect timing for you, Lauren, right? As we go over to overseas to the Admiral Isle. So go ahead, Nick. What's the latest disasters going on over there?
Well, it appears we've crested Omicron now.
Okay.
Mixed messages a little bit from some of the statisticians because less people are asking for tests, but the sales of antigen tests have gone through the roof, and that's partly because of a changed strategy recently where the government, because of the pressure on PCR testing, advised anybody over between 5 and 39 should do antigen test first, and only if that was positive have a PCR. So that's kind of changed the dynamic for the number of people demanding tests, but the positivity is still 42% for those being tested. I think yesterday there was over 10,000 cases, which Last year would have been a record, but because we've had 15, 16 days consistently now with over 20,000, it's
Still a record.
not such a big number. Yeah. We've had our millionth case diagnosed in Ireland, so that person's going to get a medal. So it'll be 20% of the population now have had COVID in Ireland. The vaccination rate is 82% now, full vaccination above the age of 2. Boosters are 60% of the population, but that is reflective of the fact that certain age groups have only been brought into that category to be eligible for a booster recently. So you've got people in their 80s and 90s are 90% vaccinated. People above 70 are 89% vaccinated. Above 50 are 63% vaccinated. But then it drops down to, for the 12-year-old group, down to 18%. But that's only because they only became eligible in the last week of 2021. So the booster program is moving ahead. Slight complicating factor is that people were off for the holidays. So a lot of people attended for boosters. Now that kids are back in school and they're trying to vaccinate the kids are not getting to the vaccination centers. So it's causing a little bit of disruption because they don't go into schools to do it. And they're going to have to come up with a new strategy to try and get that volume of kids done in a short period of time.
Got it.
But
okay.
Because of the daily caseload going down, it's probably turning a corner now on the numbers.
I was encouraged, Peter, remember that slide you put up a couple weeks ago? Was it from the University of Florida, where they really did a great job of predicting what was going to happen over the last 2 years? I thought that was a cool slide. If you can send it out again sometime, that'd be great. Or if you could put it up for a second, but it did predict that this was going to happen. And we were all being, a little skeptical. And the other thing, keep in mind, even if it's going downhill, it's really high, right?
It's still really high, yeah.
So you're still got risk, even if it goes away in 2 weeks or 3 weeks or 3 months, it's still there and it's floating around.
So we have a hospital inpatient capacity of 11,000. There's currently over 1,000 people with COVID in hospitals. There are, I think, 300 people boarding in EDs this morning, and that's a figure that's kind of staying stable. Usually around Christmas time, it goes up to 600 or 700 because of the demand at that point in time, but all elective surgery is cancelled at the moment, apart from cancer and severe emergencies, so that there's a lot more bed spaces available.
Your big issues really are what Sandy pointed out about the rural hospitals, because you're a rural country, not an urban country, right?
Yeah.
And you're having those same problems. Sandy, had you heard him talk about that before? I don't know if you had.
How much you might be gone?
Schneider? Oh.
Okay,
I wanted to have you use a quick reiteration for her sake in case she was still on, but if not, then we'll move on. Okay, I interrupted you. Go ahead, Nick.
Oh yeah, Eileen had asked last week, was there data on the wastewater examination? I can't get it. I've just tried a couple of different places. I cannot get the data on that.
Okay.
So I have no idea.
They are. I'm out in San Francisco and other places in California. They are noting that the wastewater indication is there, that it's going down. Okay, they're seeing less of it. So in parts of our country, that's another way. That's why they've been tracking it, and it gives you kind of a glimpse of all that. All right. With that, hey, let me talk to then. I think, is Dave Hansen on by any chance from Society of Critical Care Medicine? What's the ICU bed situation and circumstances? Anything else to add? Are you reflecting the same thing, that's not as bad as it was before?
Yes, good morning, Dr. Pepe. I would say from the critical care perspective, the picture is much like the picture that Sandy painted for the ED. In addition to overcrowding, we have the issue of no staff availability, and then we're also beginning to hear reports from our members that they're in fact coming down with COVID themselves.
Yeah,
so, which is creating a real problem for our ability to care for these patients in the ICUs. So.
Correct. Okay. So it sounds like they're a little more fortunate over in France, but not so much here. But so, and I think it's long term going to be a problem, as she pointed out. So that's something we're all going to have to keep an eye on. All right, so I'm trying, anybody else have any things to plug in there? Or John, do you have anything to report on before I go over to the didactic reports I want to give? John Drew, anything, we
Oh,
should,
yeah. Paul, sorry, I didn't know which John. There's an article that may be of interest to everybody on this call. It's a pre-publication article, and I can actually share it here as well.
and Rob, anything to report from your end in DC, especially with your infectious disease background?
I just have one thing, but go ahead, John.
No, let's,
Okay.
as he's preparing it, he's gonna set it up. Go ahead and give us the one thing report.
This means I have to actually find my slide. Okay,
Oh.
hold on.
All
This
right.
is gonna
never
take me a
mind.
minute.
Okay, good. And then for those of you who've not been on the, Rob Holman's not only has an infectious disease background, but he's the medical director for Washington, DC. They've had a very interesting, thing. Yeah, I got to see that model you set out, Peter, there. It's in the chat for those who want to see it. Okay, Rob, go ahead. What do you got there?
So I just
are we-
wanted to show, I presume you can see this now.
Yeah, Omicron is purple and Delta
Yes.
is
Yes.
the amber, whatever.
So this is the data from the CDC site that does show what we all knew in practice, that
Sorry
they do
about
have
that.
data to support this. I just want to offer, this is really for Dr. Pepe more than anybody else. And this is because of the widespread mispronunciation of the Omicron variant as Omicron or Omnicron.
Yes.
The WHO has officially changed it back to B.1.1.529.
Oh, cool.
Okay, just wanted to let you all know that.
So should I
Okay.
go .1? Okay, got it.
Yeah.
Can I write that down, or I guess I have to memorize it now? So, okay. Well, thanks for that. That's actually an important slide. So thanks very much for letting us know that, Rob. Okay.
The purple wave has happened.
Yeah, that's right. The purple wave is here. So that's great. Well, thank you so much. So let's go ahead. John, want to go ahead and give us your report?
Yes, let me know when you can see the slide here as well.
I can see this slide here.
Yeah, this is of note. The real reason I'm presenting this is the first head-to-head comparison of Omicron versus Delta, and from a group of investigators, including sponsored by CDC, as well as Columbia and Harvard, I believe. I'm going to cut to the chase, moving quickly. And basically, it was the viral dynamics, and what they did was the cohort analysis of MD8 players who were tested every day or every other day. And I'm going to move through the slides fairly well. This is a very busy slide. I'll send this out to all the people on this call, but basically it looks at viral dynamics. And what they're looking at is the viral load as measured by the PCR cyclic time here as well. And obviously the lower cyclic time, the higher the number here as well. So what is interesting is the following, that they looked at both Delta and the viral dynamics and compared it with Omicron, or whatever Rob says it is supposed to be called. And this is the Delta, this is the Omicron slide. But when you put them side by side, I'm going to stop here as well. There are about three things that come. Number one, that you're at day 6, 7, and 8, you're still infectious with either Delta or Omicron, about 10 to 20% here as well. So the CDC clearance of healthcare workers at 5 days is taking a chance of up to 10 to 20% still remaining infectious, assuming that the CT values are less than 30 are still infectious. But when you have CT values less than 20, that's probably really high. The second one is that there's a marked difference between the clearance of Omicron and Delta, with Delta being longer and the Omicron being much more shorter and fairly smooth in the curve. But these are small numbers here as well. So in summary, highlighted in red, what do we know about this study? First of all, it's the first study looking at Delta versus Omicron as far as viral dynamics. Again, this is a CT value, not culture, but it's fairly comparable. The incubation of Omicron when compared to Delta is quicker by 1 to 2 days, which validates our anecdotal observations. Number two, the clearance time is a bit quicker with Omicron than by Delta by 1 to 2 days. And number three, Omicron has a much initial higher viral load than Delta, which explains the highly infectious nature of Omicron when compared to Delta. but the peak viral concentration of Delta is higher than in Omicron. So you have to be a little bit careful what you actually say. The other thing is that we're looking at nasal swabs, not the bronchial swabs here as well. So one needs to mind they're looking at basically the transmission of virus, not the actual infectivity and the location of infection here as well. So I think in truth here, this sort of validates the concern that many infectious disease individuals have on the rapid non-testing of healthcare workers after 5 days, which I have a lot of problem with. And we moved to about 7 to 8 days, depending what it is. Well, and number two, it also validates the anecdotal observation of increasing transmissibility and increasing viral loads. Back to you, Paul.
Okay, thank you very much. So again, Peter's modeling is in that sidebar if you guys want to pick it up. And Peter, if you could send me a copy of it as well in the email, I'd appreciate it, and I'll try to send it out. Jim is unfortunately tied up in the fair meeting in Florida right now, so it couldn't be on, but I'll take care of it. All right.
Paul?
Yes. Go
I
ahead.
have a couple of graphs just to kind of pop on if you wouldn't mind about adult versus kids. Can I just do that real quick? It's some interesting graphics.
Sure. Okay. Yeah, go ahead.
Okay, because I think it'll help everyone understand what we're seeing. So can you guys see my screen okay?
Mm-hmm.
So this is all data from England. I got this off of Twitter, a great Twitter thread. But you can see on the very top, you have England, France, and Spain. You can see the cases and the admissions for kids go hand in hand, whereas for adults, they don't, right? Cases go up, hospitalizations didn't. So that was important.
I know, or looking at the red line, go back. The red line is what?
Yeah. The blue line is cases, the red lines were admissions. So on the top three, top, it's all right. From England, France, and Spain, all the three top ones are all kids. And the three bottom ones are adults from those same locations.
I see.
You can see that when cases go up in the adults, admissions didn't, but they did for kids. This is also an interesting one where you could see the historical rise of bronchiolitis, for January 2021 and January 2022. And you can see that COVID is actually rising, but in the prior history of bronchiolitis was much higher than it is currently. This is New York City. You can see that the total number of pediatric patients hasn't changed, even though the patients with COVID-19, the pediatric patients with COVID-19 has. So it hasn't really impacted total patient volume, which is interesting. And then the last one from England, you can see here that even though cases are still on the uprise, they're showing now that the hospitalizations are coming down in England for the first time. So just, kind of interesting statistics, adults versus kids with this new wave. So that's it.
Okay, good. Thank you very much. And hey, Scott, are you still okay to stay on for say a half an hour or something like that? Scott Youngquist?
Yeah, I'm good.
Because I want to sort of give some other folks a chance to come on and all that.
Yeah.
Okay, good. So let's move on. So Miguel Henry, if you don't mind, you want to come on for a second, and do you have any problem talking about your situation?
No, our situation, let's see, especially for the LA area.
You want to tell them who you are?
Who I am? Yes. So Roxy, I'm with the United States Secret Service. I've been with the Secret Service for about 25 years. And I'm also in charge of our small medical program in our office as an EMT, and work under John Hopkins, Dr. Tang.
Yeah, and he also has to be forced to work with me from time to time too. Right?
Our paths cross quite a bit when the concerts are moving.
Yeah,
but we're seeing probably mass fatigue as far as agents and stuff are concerned about PPE protocol, and some of them are getting COVID for a second time, but we're working on it, and we're able to, now we're putting a mask, we're doing back to our mask again mandate as far as everybody's got to wear a mask in the office, and definitely when we're doing our protection assignments.
Good. And then we've had our own discussions, and you've been on some of those where we talk about a mask is not a mask is not a mask. So are you guys using KN95s, N95s, or what?
N95s, and I really push that. Some of them are still using the surgical mask, but I said for the next couple of weeks, we're really pushing the N95s.
Okay, got it. And then one of the reasons I was also brought you on, Clayton Kazan's on, and he's the medical director overseeing the SoFi Stadium, and you'll have some connections there coming up. So I want to make
Yes.
sure, just in general, I want to get you guys to know each other. So I'll try to introduce you later. But when you guys get emails, you'll do that. Clayton, you want to come on so you can say hi real quick?
Yeah, I'm here, Paul. Thanks. I'll put my email in the chat if you want to reach out.
Okay.
Okay, excellent. I will after the meeting.
And then
Thank
the other
you.
thing is Scotty's doing the sorry about that. Scotty's doing the what do you call it show? The the
Halftime.
halftime show. So I'd like to maybe you can help him get plugged in with Scott as well. So okay. So thanks. And Clayton, how did it go? Good game, by the way, other than that, right, for you guys, right? But yeah, what are the issues that you're having out there at the stadium? They did the playoffs yesterday with the Rams and a very loud, boisterous crowd. So are you looking to see if you're going to get a surge from that?
I'm not sure what public health is following. There was a lot of concern that our public health would step in and the Super Bowl might get canceled or get moved.
Yeah.
So far, the city, the county, and the state have all affirmed that the Super Bowl is on. And it's going to stay kind of no matter what happens with Omicron.
Yeah.
But no, actually, we're just hoping that the Super Bowl is a home game.
Okay, got it. Well, yeah, that's right. That's a good plan. All right, well, good for you. It was great to, and my kids knew Matthew from high school, so we're really happy that he did so well. All right, so let's now roll over to a couple. Anybody else have anything to insert before I can do some more didactics here? I'd love to take anything from anyone. All right, so let's start with Scott, just to be fair to him, Scott Youngquist. And so I'll give a quick background. We've all had this thing about, do we use epi, do we not? And some of our studies that I've been, including ones I've been involved with, the earlier you gave it, the better off you were, like in the case of kids, but they were non-ventricular fibrillation cases, they're for the most part, and it kind of makes sense. But on the other hand, it is kind of somewhat delayed in the kids. And we did have inklings, and Scott will talk about that in a second, from the ROC, that actually the earlier the epi was given, the better off the outcomes were. And there's some biases that may play into that a little bit. But on the other hand, what I did want to give to you, I'll have you take over from there, Scott, is that he's now looking at the concept is, think about what we're doing with the head up CPR. That's going to be a basic life support function. And so what if we can make IM epi a basic life support function? And this is the first step towards looking at that a little bit. So with that, what's the anticipated benefit of epinephrine? Scott, take over. Everybody knows Scott Youngquist, our Eagle from Salt Lake City, who's been doing really vanguard work in resuscitation over the years, everything from putting the TEE down there to see the best hand placement to whatever it is. He's just always out there doing it. And we're just so glad to have him part of us, and just a terrific person. So take it away, Scott.
All right, great, thanks. So the rationale for this approach of early intramuscular epinephrine is to try to get that first dose, an effective early dose in patients, to shorten the time to return of spontaneous circulation, because we know epi produces ROSC in patients that don't respond to initial resuscitative measures. And it's very time dependent. I'm going to skip over that one. And go to a slide from the Paramedic 2 trial. So as you probably know, 33% of the time a drug was given IO, 66% of the time IV. And if you look at the time from 911 call to administration, it was 22 minutes was the median time. They did a little bit of a subgroup analysis looking at time to administration as it varied between patients. And you can see that there are differences in these curves. They're not statistically significant based on the sample size, but earlier administration is suggested to be better than later administration based on Paramedic 2 trial zone data and on multiple observational studies from the ROC Consortium. A recent one showed that if the first dose of epinephrine in shockable initial rhythms was given within 6 minutes, 4 to 6 minutes, something like that, patients had the best outcome. So this could all be, biased, of course, but we know that low flow time, the time spent during CPR until ROSC, is highly associated with your neurologic outcome, in addition to those other things like whether you were witnessed in your initial rhythm. So I thought about IM as a rapid way of doing it. There's some preclinical data for that. The advantage is EMS knows how to use it. that BLS could potentially do it and is likely to be faster than IO or IM. So there's a few preclinical studies showing it is absorbed during the low flow state of CPR and does raise coronary perfusion pressure, generate ROSC in both pigs and rodents. So in late 2019, we protocolized a rapid first dose of 5 milligrams of epinephrine into the lateral thigh of patients who were either non-shockable or didn't respond to the first shock and were still in arrest at the second rhythm analysis. We published this in Resuscitation Plus, so you can get the full study results. But the bottom line was, it was faster. It turns out that we were already very fast compared to the Paramedic 2 trial sites in giving our first dose of epinephrine by IV or IO. We saved about 3 minutes, which is consistent with the Rampart trial of benzos, either IM or IV for seizure, refractory status epilepticus. And then in multivariable analysis, there was a signal toward benefit. This was not statistically significant, of survival to hospital discharge, which was stronger than functional survival as anticipated for a drug that produces ROSC indiscriminately, regardless of brain injury. We controlled for a bunch of things, including the year of arrest, but this is observational and likely to be affected by resuscitation time bias. There were no safety issues with this. You know, we've been giving drug through the pants to patients in anaphylaxis for decades now. Patients did have a higher number of shocks when they had a shockable rhythm in IM treated groups, and they received on average 1 less dose of total epinephrine. So still a lot of unknowns around this, but has the potential promise of being a way for BLS heavy crews to administer the first dose of epinephrine and get some effect early on. The dose is unclear, but was extrapolated from the basic science literature. And so we showed some promise in this observational analysis. We're planning to develop a clinical trial in this area with Henry Wang is working with me on a placebo-controlled trial to really figure out if this is beneficial. If it is, it could be a potential game changer, particularly for rural EMS or areas where getting an ALS provider on scene is delayed. So that's the basics.
Thanks very much. Before I go on to questions and all that, one of the things that, hey, Remley, are you still on? I think Remley gave a talk the other day about the confounders that you could get in clinical trials, and that's been a problem. That so you guys do a good job, hopefully, because I think previous epinephrine trials, when you look at the subpopulations that were studied, the people who had controlled their ventilation had really good outcomes with it when they gave it earlier on, whereas the other groups diluted that all out because they were overzealous ventilating. So, you know, just making sure you guys will be controlling for, you know, those kinds of things like ventilation, CPR, and all that kind of thing. And you guys do a good job out there already, but just keep that in mind as well. So but fantastic work. I think this is great. And you were reading it to the same way, possibly where we could be going with this eventually, right? And so John Ju, you've done a lot of work in this arena in the past. You have your own opinions. Can you give us your opinion here?
Thanks, Paul. I actually think Scott is onto something here as well, and I firmly believe that the data is probably correct here. What I'm actually, Peter and I have been texting each other regarding IO, femur IO versus tibio IO, and so I think it depends upon the way your agency is configured. I think IM epinephrine is going to be a game changer, at least for the initial resuscitation of children with BLS providers. We're almost all ALS here, so it probably won't affect us. For us in ALS, I actually think we're going to probably be switching to what Peter's doing into the femur IO and the absorption, because about 20 or 30% of our tibial IOs, and especially small children under the age of 2, get pulled out. We have no trouble putting it in, but we have a lot of trouble keeping it in. Does that make sense as well?
Yeah,
So,
well, how about the shoulder in adults?
The shoulder in adults, the animal data and our data would suggest that the humeral IO is equal or better than the tibial IO in adults as well. So we have noticed anecdotally that our ROSC rates for non-shockable rhythm has basically doubled with the humeral IO compared to the tibial in adults as well. And so that we switched to almost all humeral IO in adults and cardiac arrest.
So I not to get away from it too much from the issue of the IM itself, though, as a little faster route,
Yep.
and, you know, because these guys were pretty fast, and then maybe it is going to be possibly, you know, a thing that could be used by whoever's first in. David Miramontes, you were leaning towards, you called the head up CPR a basic life support function. What do you think about this? Would this be something you would entertain, or what's your reaction to this? David, are you there? David Miramontes? Hope I didn't catch him off too much off guard. So probably didn't know I was going to pitch to him, but you know.
Sorry, I'm sorry. I was off.
Okay, it was a ball anyways. Let's try one more strike. So is that, you know, you were one of the first people to say, let's use head up CPR approach, you know, the bundle as a basic life support skill. What do you think? What's your reaction to this? Is that something we could possibly add to the mix down the line if we could find the right candidates?
Yeah, I think it's a good idea. We've been using IM epinephrine for centuries for anaphylaxis. The only thing I have to worry about is in cardiac arrest, the skin is not a well-perfused organ. And I don't know about its absorption, but obviously Scott took a stab at it. So that's awesome. And then CJ put our link to the Femoral IO article in the chat, by the way. We're an all ALS system. In fact, our BLS providers can do IOs. So it's Texas, we do whatever we want, right? So for us, this is not an impediment. For those BLS services, I think it's great to use an EpiPen if you can afford it. But I think moving on the right track. And then Peter, you need to put your link for your femoral IO hand-heavy minute in the chat. That was really well done. That was a collaboration with me and Peter and the Body Lab up at Scotty Boulder's office.
Okay, good. All right, well, thanks a lot. I want to use that possibly here. Anybody have any questions for Scott or anything else or comments to make before I switch over to the next? I'm going to go with Peter in a few minutes here.
Paul, there's one article that I'm sure Scott knows about. It was published in Resuscitation by the Canadians as well as the collaborators here, where they actually showed that the IV route in kids with resuscitation is superior to the IO route. And I'll have to look for that article, but it was a little bit surprising. So Seattle King County switched to IV in pediatric resuscitation. I don't know what their success is, but it was an interesting observational study.
Which also brings up is that we know, like in the studies that Paul Banerjee did in Polk County, Florida, that the earlier the drug got on board with the kids, the much better the outcome. It was part of a bundle that included everything else getting done faster as well, you know, in avoiding CPR on the move and all those kinds. There's all sorts of other factors controlling for ventilation, but nonetheless, it really was one of the factors that, and then it seemed to get better the faster they got the epi on board as well. So this is, I just wanted to put this on everybody's radar screen and congratulate Scott on taking a jab at this, so to speak, right? And so thanks for the presentation. Anybody else have any questions or comments before I roll on to the next issue? And Lauren Maloney, anything to report? We haven't had you on for a while, so I just wanted to see if there's anything you have to say, or just say hi anyways, right? So,
it's certainly listening to everybody else, it doesn't make it seem as though it's currently as horrible as we think it is, but boy, oh boy.
Yeah, okay.
We're all done.
And you're up at Stony Brook, right? In Long Island, right?
On Long Island.
Yeah, right. Okay. So, all right. Well,
Jay says hi.
Yeah. So we decided that because Omicron came in, that or whatever I got to get the number right. Rob Holman could tell us, but is that we'll probably extend the cardiac arrest study out a couple more months to see what Omicron did, to see if it increased the cardiac arrest or predicted cardiac arrest. Okay.
Absolutely.
Okay. Good. All right. So then let's go on, Peter. Chris, you only have a few minutes. You're working in the emergency department in San Francisco right now, if I remember, right? Not too far away from me. And Chris, did you see where I'm located here? I don't know if you can catch it or not, right? I'm on the airport grounds there. It's fantastic.
That looks like the Grand Hyatt at the SFO.
It's amazing how you're able to know this stuff. You're just something else. No, but anyways, thank you very much for the tour yesterday at San Francisco Journal, bringing back old memories. And everybody who says that, if you remember the 60s, you weren't really there. Well, I was there. So anyways, but anything to report from San Francisco that I didn't know about now that you guys are all back at work and all that there?
Yeah, Paul is one of the few to remember actually working in some of these buildings that were built in 1915. So some of them are artifact. He remembers actually working in those buildings and when they were medical and surgical wards. So
That's true.
not necessarily in 1915, but the buildings that were. Now, you know how we're doing in San Francisco. They had predicted our peak to be today at 12:06.
Okay, cool.
So I'm in the ED and I'll be there. I'll be there at 12:06. So I'll let you know. We're kind of teetering at our highest levels of hospitalizations and ED visits right now that we have seen in the pandemic. But in general, we're seeing there's volumes are high. In general, people are less sick, but just because of the pure volumes, hospitals full and we're dealing with the same things that everybody else is.
Yeah. So yeah, just I thought it was fascinating. They said right at 12:06 it'd be not 12:07, but 12:06 it would be peaking out, which is really kind of cool.
The data's getting better. We're getting more specific.
Yeah. Okay, good. Well, anyways, it's always great hanging out with you, Chris. And so thank you very much. And, just it was great hanging out with Jane and Anna. And so thank you so much. And the dogs, of course, right? So, so, all right. So that's it. And then let me see who I'd like to go to next. Well, Peter, can you go ahead and give us a quick rendition of the first part of your talk that you gave your day? And this goes along a little bit with what I was going to originally sort of pivot off of Dave Miramontes, because his work down and as he said, he can do whatever he wants, but he's really gotten exemptions to change sometimes the standards of care because he's not necessarily agreeing with what those are. And I think that you can probably give a cautionary tale here about why we should be a little cautious about some of the things that that are being called standards when, as far as I'm concerned, they're guidelines by a group of people that may be expert or maybe not based on what you're about to tell us. So, all right, so take it on.
Excellent. Paul, thank you. And it was great to see everybody in San Diego this past week. Seeing people in real life was actually pretty nice. I'm gonna only give 1/3 of this talk, which is just the top part, the ventilations part, and maybe we can do the others on a future date. And so the ventilations, everyone knows that PALS back in October of 2020 changed from 10 breaths per minute, or 1 breath every 6 seconds, to 20 to 30 breaths per minute. So they doubled and tripled the recommendation during this new guideline, and it was a 2B-CLD, which is weak and limited. I'm not going to go too much into that now, but whenever you see that, you should just go look for the study, and that's what I did. Before showing you that study, and this is things I learned from Paul and people like Keith Lurie, that the BVM is really a device that helps blood flow. It may be more so than it affects even oxygenation and ventilation. Because of the decrease in pulmonary resistance and so forth. So just making clear to everybody that, skip slide, there you go, that with the BVM, it affects flow because of the fact that any increased pressure in the thorax will decrease LV ejection, but maybe more importantly, it'll decrease venous return from the brain. And you heard Scott talk about that earlier, how important that is. So positive pressure is not good for the heart, the brain, or flow. It's good for your oxygenation, so your PaO2 will go up at the expense of flow and more than likely neuro intact survival. So we have data from back in 2004 from both Keith Lurie and Tom Aufderheide, where they did a study in swine, and they looked at changing one variable after putting those pigs into arrest, which was the ventilation rate. And you could see that the pigs who got 12 breaths per minute versus 30, you could see the survival, and look at the cerebral perfusion pressure in the 12 versus the 30, and of course you see the survival there. So it's pretty clear that the BVM affects flow and therefore affects survival. And so what I want to bring out,
Peter, can I interrupt for a second? Go back to that slide.
Yeah.
You may be asking what the CO2 was. So what this was very elegant. What they showed was people thought, is it a hyperventilation? In other words, hyperventilation is lowering carbon, by definition, is lowering carbon dioxide, not fast breathing. But does hyperventilation, in other words, a low carbon dioxide, cause alkalosis and therefore depress the heart and all that? So what they did is they piped in CO2, so you didn't have an alkalosis effect, and it was all the same, right? So it's all positive pressure ventilation and eliminate it. But going back to what you said before, I just wanted to say you need to have a good lung inflation to get the blood through the, to open up all lung segments of blood can go, but you just can't give it, a lot, okay? You just have to do it, intermittently, just to get the lungs inflated, but not to keep continually, giving a faster rate. So just make sure that was clear. Okay, so go ahead.
So Paul, what you're saying is a contrarian point of view is that instead of smaller, more frequent breaths, you're saying a larger breath less frequently.
Yeah,
right?
that's very simplistic,
Right.
but you're right. There's more to it, but that's a good start, right?
Right. Right. Awesome. Okay, so I'll continue. So this data that changed the guidelines may surprise you. Hopefully everybody's sitting down. So this came out of a multi-center ICU study, only 47 patients. But take a look. All of them were in the ICU, either the regular pediatric ICU or the cardiac ICU. 72% of them had an A-line already in place prior to their arrest. 85% had a central venous line in place. And 77% of them were already on a pressor. But wait, there's more, because all of them are intubated and all of them had end-tidal monitoring. So the only time a paramedic will come up to a situation like this is never, unless you're going through an IFT, an interfacility transport. So this clearly is not the patient population we deal with in EMS.
And
then
presumably
when you,
these guys were all volumized, they had optimal volume status and all that too, right? Because a lot of our kids
correct,
don't have that, right?
correct. They had all that. Everything was just perfect, and then they went into arrest. And so other things important to know is that 60% of these children had a pre-existing condition of congenital heart disease. Again, not a population that we look at. And then maybe the most important part of this paper is that the presenting rhythm for a majority of these kids was bradycardia with poor perfusion, 74%. That's the entire population of people who essentially came back to life, except for that one VFib kid. All of the patients who had asystole in this study died. So what did they find? They found that if we double and triple the ventilations, we get quote unquote more kids back to life who had a bradycardic rhythm and who had all those other pre-existing conditions that I mentioned. If you look at the asystolic patients, none of them survived. And then even more intriguing is that not one patient got a standard 10 breaths per minute ventilation rate in all of these 47 patients. So it's an observational study, multi-center, that didn't really prove anything of value to us in EMS. But lo and behold, this is the data that has been used to change our practice. So I would invite everyone to go look at that data. And if you go actually look at the appendix, which you got to really dig for this thing, the guy who wrote this up, Jonathan Duff, who's an intensivist from Canada, wrote that it's a one observational registry that reported increased ventilation rates during intra-hospital cardiac arrest in intubated ICU patients was associated with improved neurologically intact survival. But if you just read that one conclusion without knowing all of the other information, if this is on Twitter, you would think, hey, this is a good idea. For EMS, I don't think it's a good idea. ILCOR didn't think it was a good idea. They figured to stay at 10 until they got more data on this topic. So that's pretty much it, Paul. The last thing I did want to mention, a study that you were involved with is with the Paul Banerjee study out there in Polk County, where not only did the epinephrine times get better with the bundle of care and neurologically intact survival, but they went to one breath every 10 seconds. So they went the other way and had better outcomes. So I think we have a lot of work to do in this area, but physiology is physiology, and I'll pass it back to the king of physiology, Dr. Paul Pepe.
Well,
Thank you,
one
guys.
thing again to say is that, yeah, Paul may have lowered the rate to 1 every 10 seconds, but he had a large breath. A larger breath hits more lung zones, so you get adequate lung inflation. That determines oxygenation. 2 is that it's a more efficient breath because there's less dead space per breath. So you get more alveolar ventilation. A larger part of that breath is alveolar, so you're clearing more CO2. So you don't need to clear CO2 that much. So that's part of the reason why physiologically that'll work better, and you get better blood flow through there. So anyway, so that's a good start. I just wanted Peter to have that, and wanted to make sure, because he wrote editorials, and there's probably some people that want to have him taken out, but we're all part of the resistance here. But we wanted to point out why. What I thought was really cool is that he did it in a very, very, I thought, objective manner, and said, hey, don't take my word for it. bring it home to that article, bring it home to your journal club, right? For your residents or whatever, and see how far that's going to get, right? In terms of determining changes, international guidelines. Did OCOR change their guidelines as a result of that paper? International
No.
Committee? Okay.
Right. No. Yeah, they stayed the same. And Paul, just as a last point, what I would love for everyone on this call to consider is, we're now our own subspecialty. And so we shouldn't be waiting at the bottom of the mountain for them to bring the tablets for us to say, yes, we will accept. We ought to review the same data and then put it through an EMS filter and decide whether it's okay for our agencies to do that. So I think we have to turn the corner here, in my opinion, on this.
Okay, thanks very much. And Chris Colwell, just going back to you, were there in the audience, I remember, right? Are you still there, Chris? He may have taken off by this point in time. I think we lost him.
I think he left.
Yeah, we just lost him. Anybody else in the audience to that? Any reaction to what you heard? Anybody else that was there besides me? So, okay, if not, then let's move on. Any comments or questions for Peter? If not, let's do a kind of a little bit of a round robin, if you don't mind. But Eileen, do you have any? Eileen Barty's on, our infectious disease guru. Anything we need to know about from your end? Eileen? Eileen's probably doing 4 TV interviews right now while she's
No, I was just on mute.
Okay. Okay, go ahead. So, but anything you can report to us, Eileen, that you have, and by the way, I'll be in your jurisdiction, just to warn you, at 9:30 tonight. So, okay. All right. So, any event, anything to report on new from your end? We're not hearing her, so breaking up. I wonder if there's a connectivity problem. All right, well, with not, by the way, hey, I see AJ's name there. Thanks again for my Eagles t-shirt, AJ. Very nice of you to do that. So really appreciate it. All right, well, first on my list here is looks like Glenn Asada. So Glenn, you want to give us a report from New York, and I'll try to go down the list here if you guys can hang in there, and then you'll know when you're going to probably show up. Okay.
Hey, sounds good. Good afternoon, good morning. Just want to say hi again to Carolina. As Peter said, she was with us several years ago, so it's great to see her.
We were wondering who corrupted her. So, okay, it was you.
Yeah, we take responsibility for that. So our apologies. Really,
all right.
Good to see her. We've actually been doing pretty well statewide as well. Our governor went on yesterday to report that we've probably plateaued, and now our peak now is actually coming downward. That's throughout the state, with percentage last week of positivity 20% now, down to on the average about like 12 to 13%. New York City, we've been seeing kind of the same trend as well. Over the last 3 days, our call volumes, which I always report, is about 4,200. The previous week was about 4,600. Went actually down in the last 3 days below 4,000 to like 3,800. But we did have that snow rainstorm yesterday, and such, and people were preparing over the weekend. So, and it was cold, so maybe that's why. But everything seems to be going okay. Our sick out rates of EMTs and paramedics, which hit as high as 32%, now as of the weekend down to about 14%. So we're definitely coming back to half of our sick out rates. So staffing is getting much better for us. Volume is coming down, which is great. Hospitals are still having staffing issues. The nurses unions have been protesting at City Hall and in front of their hospitals. They're saying that's very dangerous, that the number of nursing staff to patient ratio is not appropriate. They've been reporting that. Now, interestingly, our cardiac arrest over the last week and a half, doubling. Confirmed cardiac arrest are only about 25 over the last week and a half, sometimes up to 50, almost 60 calls, confirmed arrests per day. So we're going to try to keep that trend to see what's
They
going
seem
on.
to be primary cardiac arrest, not like overdoses or anything like that, right?
Yeah, we're trying to break that down. It seems primarily cardiac arrest.
Okay, good. So Lauren, there you go. That's another reason why we need to extend the study then. Okay, so go ahead. Thanks, Glenn. You guys are always the canary in the coal mine for the rest of us.
Unfortunately, right?
Yeah.
And we were able to get some NAC ambulances to assist us, which we didn't think we were going to be able to get. They were actually sent to Western New York State, and the governor was able to bring them down to us. So that helped us, and thank you to all who have assisted us.
Okay. Well, I'm going to run down 95 to Baltimore, I-95 to Ben. Ben, what do you got?
Hey, everybody. Good to see you. Thanks. Thank you, Paul and Peter and everybody else, John, for the review. I don't have much new. We still, our cases seem to be, I don't know if we've peaked quite yet. Our hospitals still have some of the similar challenges as highlighted in this previous, in this discussion, meaning that we've been dealing with diversion for quite some time. So I think we continue to work on things like the messaging and, for the first time engaging City Hall and really taking to the media waves to talk about how kind of strained the EMS system is. We have seen the deployment of National Guard, but they are only helping with testing. I think this is, my idea of this, or my interpretation is like, this is one of the longest standing evolving disasters that we've seen in public health.
Yeah.
So I wonder if there couldn't be some more sort of deployment to the ED, where we have basically the bottleneck occurring both there and at the upstream. So really nothing new to report there, but continue to work on all of our surge plans.
All right, well, thanks a lot then. Let's
Of course,
go.
thank you.
Okay, good. Let's go over to Milwaukee. Ben, anything you can tell us about Milwaukee that's new, different, or than here, or just pass, right? Ben, are you there? Be prepared, people. I'm coming down the alphabetical list on the participants list here. Ben, are you there? Ben Weston? Okay, guess what, Chris? You're up. All right, Chris Kahn. San Diego.
Hi. First, I want to say thanks everyone for coming to visit. I hope you all had a good time, and the tsunami wasn't that big, so that all works out.
I was watching it from the hotel room and didn't see. I just saw the extra waves. It was good for you. And I got to go to Cali. Have you been there yet? The restaurant?
I have not.
Okay, good. Yeah, it's good. I'll talk later offline to you. It's great. It was really good. A good trip out there. You guys, unfortunately, it's so good. Great place to eat. So, right. All right. Anything new happened in San Diego that we should know about? Working on.
We're having so many issues with diversion that we were able to talk the county into suspending ambulance diversion for a 14-day period. We're about 5 days into it. And so far, it looks like our offload delays have gone down in our episodes of what we call level 0, having no ALS ambulances available to respond. Looks like that has gone down as well. So I find that encouraging. And I'm hoping that it stays that way. And then we can hopefully have a talk with the county about extending this for a longer trial, such as indefinitely.
Okay, so before I go further, Ben, could are you out there, Ben Weston? If not, Chris, what's happening in Houston? Hey, Chris.
Okay, yep, I'm here.
Go ahead.
So we're the same as everyone else, longer response times, hospital holding. One interesting thing to harken back to an earlier talk y'all were talking about is CMS just withdrew the Medicare Medicaid contract from one of our hospitals due to EMTALA violations, and we're getting lots of pushback from our congresswoman and mayoral staff because we obviously stopped transports to that hospital because the basis was on patient safety concerns.
Tell us about what kind of specific EMTALA violation it was.
They have a double door entrance to the emergency room, and they would lock the outer door and yell at us through the glass. They would not let us in if the patient didn't have a driver's license, because if they couldn't register them, they couldn't treat them. We would bring other people in that were too obese and they're not a bariatric specialty hospital, and would refuse our patients. They also, non-related to us, so we filed 3 EMTALA complaints. Non-related to us, they had an affiliation with the Caribbean Medical School and only staffed the ICU with a Caribbean medical student overnight. And during COVID, they had emotional problems and would abandon the hospital in the middle of the night. So this has been dragging on and finally was finalized while we were in San Diego.
Okay, well, thanks for the interesting thing. How's happening with the sewage waters? The numbers, does it look like there's less COVID or Omicron around?
Yeah, the last week's numbers show that the cumulative burden in the sewage has decreased by almost half, I believe.
Okay.
So we hope that will correspond to, ER traffic and stuff.
Yeah. Doesn't mean it's gone and you can't get it, but it's maybe it's swept through our population pretty well.
Yeah,
So,
exactly.
hey, so let me jump over to Crawford Beecham in Philadelphia. So if you don't mind, Crawford, what's going on there?
Hi, everyone. I snuck out for a second and was on a conference call regarding dealing with diversion issues in Philadelphia. And sorry.
Diversion is the topic of the day. I'm glad we
Yes.
let off with my topic. So, all right.
I think we're all more depressed by the time we're done the conversation than when we were when we started, just trying to figure out so many different factors involved in offload time and stuff like that. But
Yeah.
anyway, at least we're starting a conversation with a lot of partners.
Yeah.
And otherwise, yesterday, several of us from the fire department went to the funeral for the 12 family members in the big fire in Philly 2 weeks ago, which was just, it was just a horrible, it was a joyful, horrible experience, if that makes any sense.
Yeah. Okay.
Anyway, it's just all the other same problems that everyone else has been having.
Okay, things are more the same today than they ever have been. Okay.
Yes, exactly.
Dwight Eisenhower, great quote.
Yes.
I would Yogi Berra used to say stuff like that, but that wasn't his, so it was good. I actually make up my own Yogi Berraisms. I told my boss the other day, I want to thank you for doing a thankless job, right?
Yes.
All right, so let's move on. Let's jump over to Doug Swanson. What's anything new to report from your part of the world in North Carolina, Doug?
Yeah, unfortunately, nothing to report. The same as everyone else is seeing.
Okay.
Hospitals at a record high now. I've got 180 COVID positive patients in Carolinas Medical Center, which is one of 8 in the county. We've extended response times to a number of our low acuity calls so we can continue to just really primarily hit those high priority calls within our goals. That seems to have been working well thus far. And the best thing is that when hospitals got together and decided nobody will go on diversion, because we did have just essentially 24-hour-a-day rotating diversions among all the facilities. But that's worked out really well. And like others have mentioned, I hope that it is something that we can show that it works and continue it past this point.
Okay. Now, do you guys have football in your area of the world? Is that right? Is that right? I see all these football things behind you.
Well, we did. We didn't make it past the end of the season, though.
Yeah, neither we in Dallas as of yesterday or 2 days ago. So, all right. Well, listen, I just wanted to say congratulations on at least surviving the season too. Yeah, it was as best you could. But anyway, so thank you so much and for your report. Love having you here. Always, that kind of thing. So let's go to Mark Conrado in Minneapolis and just anything to report on there. Hey, Mark, are you there?
Here. There we go.
Well, what's the latest in your? Yeah, go ahead.
The latest, the more things change, the more they stay the same, unfortunately. Our diversion has really not impacted everybody the way they are. I'm sorry, doing away with diversion that we did 2 weeks ago. Really have not heard anything with people complaining or changes in practice patterns for EMS.
Yeah. Okay.
So all the fear that was there is gone, or at least we're not hearing it. The hospitals are unfortunately still jam-packed. We just literally, I worked last night, and out of a 20-bed ED, we had 25 patients who were waiting to be admitted, and because they were stacked up in the hallways. We were literally seeing patients in the hallways in the triage area. So that part hasn't changed. EMS volumes are actually holding pretty steady, which is good.
All right. Well, let me move on so I can make sure to get through the rest of the group. Mark, how about San Jose? Anything new there? Yeah, it was great seeing you, by the way. It was like terrific seeing you.
Yeah, no, our biggest issue here is modifying our work restrictions. We finally did actually get rid of the requirement to test immediately after exposures in conversation with Sarah Cody, the public health officer, working through a lot of reductions in police staffing as well for the San Jose Police Department. Our sewage data is showing a significant decline in the case rate, but right now the hospitals are continuing to show increased numbers.
Sure, they're going to
So
continue for a while. Yeah.
yeah.
So it's great. I'm glad to say I try to get hold of Nicole because I've been up here in that area. I was going to try to catch up with her, but so it's all right. I said hi. I'm heading out in about an hour or so. All right.
And I don't have.
Forward to Mark Ecknott, if you don't mind. Mark, what's happening in Austin?
Good afternoon or good morning, Paul.
Yeah, where I am.
You are. More of the same in Austin, record numbers of hospitalizations. Certainly seeing a decrease in the percentage ending up in the ICU as compared to previous surges, about 1 in 5 hospitalized patients in the ICU versus 1 in 3 during previous surges. So the ICUs certainly have not been as impacted. We're continuing to utilize our telehealth program through our office. We've just hired a second PA to help with that, and hiring 2 more in the next couple of weeks to decrease that load. We're knocking off about 20 patients a day via telehealth that aren't going to the ER, so that's helpful. The other thing that we're doing is distributing pulse oximeters to the local ERs as well as through our community health paramedics, so that it gives us a little more comfort in disposition of those patients to home. So
yeah, and then you're
doing what we
saying,
can.
and so when you're saying to use the telehealth project, that's the thing Mark Eckstein presented to us here on the program some time ago.
No, that's our program. We're still in discussions with Mark on.
Oh yeah, to tell you that. So that's a telehealth program you're doing, because you and I had talked that you were looking at that. So that's great. Okay, cool. And then let's see. The next thing I was going to say.
Paul?
Yes, go ahead. Yes, who's that?
Yeah, just to mention, we actually today is our launch day with Mark's system, Tele 911, up in Palm Beach Gardens. So
let us know how it goes.
It's exciting day. Yeah.
Yeah, it is. Okay, so okay, anything else then, Mark? I noticed, Mark, that you're wearing your, looks like it's SWAT day for you, right? So
it is SWAT day for me. Nothing else from my end. We're
okay.
Still, just as a reminder, we've moved to that medical practice model for our department. We're still working on the electronic health record and billing component. So hopefully an update this summer on a successful billing program.
Okay, good. Thanks so much then. I'm going to go ahead and skip to Ray Fowler. Anything new in Dallas that you can report on?
Morning, Paul. Well, just came off a long weekend in the ER after seeing all of our buds at NAMSP. We are still packed with COVID. The predominant number of those that are coming in asymptomatic that have been exposed and just simply can't get testing and want testing, which we can turn around pretty quickly at the hospital. EMS seems to be relatively unchanged regarding transports of these patients at the time. And that's really about all, Paul.
Okay, thanks, Rob. What's happened up in Columbus?
We're fairly status quo here as well.
All right.
Yeah,
it was great seeing you walk in the hall. Sorry, I never got to talk. Okay, let me jump ahead to Scott then, because we're running out of time here. Scott Gilmore, St. Louis.
Nothing much going on here other than getting ready for a line of duty death funeral on Thursday with a high temperature expected to be 20 degrees.
Oh my God. Was it a firefighter or who died?
Yes, unfortunately, we lost a firefighter when he was looking for any occupants of a burning building, and pretty much the brick walls collapsed down upon him.
Okay, got it. Okay, Veer, anything to report from Fort Worth?
We're good. Good to see everyone last week.
Yeah, really good. So that's good. All right, let me see who else our other pals on the line here. AJ, anything you had to report? Or if we lost him?
No, Paul. I came off of mute. Not really. It was good seeing all you guys at NAMSP. Lots of good stuff down there.
Okay, good. And then let's see if I move on down. I'm trying to think who else I had here. Carolina, can you tell us where is there anything besides COVID that's that you guys are involved with? And I know you're just getting started there, but anybody anything new in that we could report out of Fort Myers, Cape Coral? Maybe we lost her, Carolina. might have lost her. So, all right. Hey, Chuck, tell us about Acadia. And you guys have had challenges. So what can you tell us in that world? Where you?
Yeah, just the multiple hospital system issue with diversion has been a common problem. And I have a single divert policy where we don't, can you hear me okay, Pepe?
Yep, yeah, we can hear you fine.
Yeah, so just a lot of hospital meetings to get the stakeholders to the table to agree to disagree on who's on divert. And that's fun. I feel like a mediator in some of those. But that's working out staffing wise. Like I mentioned before, we're doing some crazy stuff, putting people through school. We just had our first slew of grads come out, which has helped us. But again, it is a never ending cycle. So we're doing okay, keeping our head above water. And the 5-day quarantine as opposed to 10 has helped us out tremendously. But N95s everywhere.
Yeah, good. All right. And CJ, anything to report from San Antonio?
Yeah, Paul. Good morning.
Yeah.
So we have the same story pretty much as Austin. We did yesterday have the first time we've had a decrease in EMS COVID transport rates and EMS calls, and it was a significant decrease. I don't know if that's going to be a signal that continues today and tomorrow, but that is our first time in the last month that we've had a decrease. And hospitals are pretty much the same. We have a lot of vents and ICU beds available. It's really the ER that is full.
Yeah. Okay, got it. Well, out here in San Francisco, it's going to finish in about 2 hours, and it's going to peak in 2 hours and 7 minutes. I thought that was great that they predicted it at that time. All right, so let's go from CJ. Clayton, anything else new than what we heard from you before?
No, not really. We are, I believe, plateaued and hopefully coming down slightly on our spike. Our hospitalizations continue to rise, and our hospitals are still short-staffed and wall time is horrible, but hopefully we'll be on the downward swing pretty soon.
Okay, good. Thank you so much then. All right, I think I've pretty much probably gotten most of the people on the call. Terry, anything to add in from Tucson before I shut everybody down? And let's see, almost. Terry Valenzuela. Hey, yeah.
Yes, Terry Valenzuela here, and I have nothing to contribute at this time.
Okay, well, one of these things, what we should do is we should, just for fun, even on one of these calls, have you and Ray do one of your debates again. That'd be really kind of fun on one of these calls, just to liven things up a little bit more. So we miss you a lot.
I would think he'd be tired of losing by now.
Yeah. Maybe so, who knows? Hey, is there anybody I missed or didn't call on or like to say anything that's out there right now? Hope I caught everybody at least for a few minutes. Okay, I think if we've captured everybody, then I'll go ahead and let you guys go. I gotta head off to an airplane. And thank you so much again. Welcome back, my friends, to the show that never ends. And for those, I'm still going to try to run something on Thursday, which will be at 1 o'clock Pacific Coast time and 4 o'clock Eastern time. And we've had them the last few days. It's actually been good. It's kind of more of a casual chat, and it's been actually useful and helpful. And so some of the people that told me they couldn't get on today are going to meet me then. So you're all welcome to join and all that. And again, we get CME for that as well. All right, with that, I'm Paul Pepe, and I approve this message. I'll see you later. Bye-bye.